Dr. T. Sukumaran, Professor and HOD, the ICH Kottayam, former National President. So many positions he has occupied. Now he is the Chief of Pediatrics in Caritas Hospital. Dr. Balajendran, Senior Pediatrician, Consultant in Pathanamthitta General Hospital, Pathanamthitta, State Coordinator of the NRP. Now he is engaged in environmental problems. Dr. Gayatri, WHO Consultant in NDP. She is acting as the moderator. Then Dr. Tingle, he has already come. He is also a DTO of Kottayam. He is also acting as the moderator here. Dr. C. Jayakumar, the most active young president, active professor of pediatrics in AMS Kochi. Noted that he was former president. I cannot forget his smile always. He always faces with a smile. Even if he is angry, he is smiling. I am very happy to welcome you here. Dr. Darley and Dr. the other people, Bindu Kutan, he is the coordinator of Person Action Plan. I think Binu Kutan, sorry. And then Sabirdhan has not come. Sabirdhan, he is the KGMOA. Yes, most welcome, sir. Sabirdhan, he is the KGMOA president. Then our most dear Darli madam. Then Dr. Sahila, Dr. Preja, Dr. Manu. All other pediatricians as well as general practitioners, all IAP students as well as, we are all most welcome to this meeting. And IAP, today the CME is according to IAP President's Action Plan 22 promise, empowering general practitioners regarding tuberculosis. I know today we are discussing two topics mainly tuberculosis in children. It is divided into two parts. One is taken by Dr. Sukumaran, and I know he is an authority in respiratory system as well as tuberculosis, and it is being ordered by Dr. Gayatri and Dr. Our close friend and philosopher, I should say, the state court. I mean, most of the IAP, the central point of IAP Kottayam, our Balajendran is here. I think he is going to talk about latent tuberculosis. It's been moderated by Dr. Tingle. And I think this occasion, even though we are conducting a CME, everybody should enjoy it and they should ask questions so that they can remove their doubts. Many people maybe put switch off their mic, this one, but to me, everybody should ask at least some questions to the people who are presenting so that they will enjoy the CME. And I hope the CME will be a very good didactic one. I wish the CME a grand success. Thank you all. Thank you very much.
Thank you, sir. Now, I invite our very own and one of the backbones of IAP Kottayam, C. Jayakumar sir, who was National EB member 2020 and 21. He is now working as head of the Department Pediatrics, Amrita Hospital, Kochi. He is the main steering force behind many of our IAP Kottayam's success, and one of the biggest successes is Pediatric House, which was he is the person behind it. And thank you, sir, for that. And we missed your one felicitation, and now I cordially invite you to give felicitation for this World TB Day.
Secretary Dr. Preja and all the senior distinguished members of the IAP Kottayam. At the outset, I would like to say a big sorry for not participating in any of the IAP activities in the last 1 month due to unavoidable personal problem. But I promise that I will be active from next month onwards. And then regarding this topic, that tuberculosis is not a disease of poor people alone. So at Amrita, we are getting people who are very elite people coming with atypical clinical features. Most of them have a lymph node and some have fever without any focus. So it's very important that we should have a diagnosis, at least microbiological or by gene expert, before we start treatment. Because in one case, I had a child, child had marked weight loss, lymphadenopathy, and I have told them clinically that it is Manta was strongly positive, but they were agreeable, but the relatives said, no, you should have a tissue diagnosis. Then biopsy was taken and confirmed tuberculosis. So even now, the management of tuberculosis, diagnosis of mainly diagnosis is really difficult in so many situations because we can't treat them without a diagnosis. I'm very sure that we have elite speakers, Professor Dr. T. Sukumaran sir and Dr. Balachandar, and moderated by Twinkle and Gayatri, and this would be extremely beneficial for you. And even if you learn or hear tuberculosis like malaria, so that's not going to be a waste. I wish very best for this CME, and also I wish very best for Dr. Patani sir and Dr. Preja for all the activities, and also Dr. Darley, who was instrumental in bringing me, because I actually forgot about this. And thank you, Dr. Darley. Also, I wish very best for the IAP Kottayam. Thank you so much.
Thanks a lot, sir. Okay, now next I invite Dr. Beenukuttam PV, our Mid-Zone Coordinator, Presidential Action Plan, Empowerment of General Practitioners. He is chairperson of IAP Kerala State Dermatology Chapter. He is Senior Pediatrician and Neonatologist, Sanjeevani Hospital, Chenganur. Beenukuttam, sir.
Oh, thank you, Dr. Preja. First of all, let me congratulate IAP Kottayam team, Patani sir, Preja, Dr. Manu, for their excellent activities this year, especially empowering general practitioner activities. And today we have eminent two speakers, our own Sukumaran sir and Bala sir. And also we have Darley Madam, Sabrina sir, Dr. Gayatri, Dr. Tingle. All eminent persons are present. So I wish all the best for the program. Thank you.
Thank you, sir. Now I invite Dr. Shabrinath D, KGMOA Kottayam President. He is Assistant Surgeon G.V. Raja Memorial PHC in Pune, and he is the main force who has helped IAP Kottayam to conduct CME for all general practitioners. Thank you, Shabrinath sir. And now for a felicitation from you. Over to you.
Respected President Patani sir, Preja Madam, and today's eminent speakers, Sukumaran sir and Jayagumar sir, Darley Madam, Balendra sir, Beenukuttam sir, today's moderators, Gayatri Madam and DTO Dr. Tingle sir. And I'm very happy to be associated with IAP Kottayam once again, because this is our third series. In the series, this is our third session, and today we are dealing with a very important session, that's pediatric TB and also latent TB. So very happy to have Sukumaran sir with us, and we are very eager to listen to his words. As far as pediatric TB is concerned, even though there are many advances have been happening, but still it's again, as Jayagumar sir pointed out, it's still a clinical challenge. So such refresher trainings are very essential, especially for the general practitioners who will be seeing the children at first levels. So once again, I thank IAP Kottayam for making this program success, and I wish all success to this program. And we wish to continue associate with IAP Kottayam in organizing such events in the future also. Thank you. Jai Hind.
Thank you, sir. Now we will begin our session on pediatric tuberculosis. The moderator is Dr. Gayatri AV, WHO consultant, NTP. She joined as WHO consultant in September 2021. Before that, she was faculty in community medicine in Amrita Medical College, and she did her MD in community medicine from Pushpagiri Medical College. Over to you, madam. Gayatri, madam.
Thank you. Hope I am audible, right?
Yes. Yeah.
So good evening, one and all. So thank you for this opportunity I gave to Kottayam. So coming to the topic, pediatric TB. As actually pediatricians, all of you know, in India, as of now, 3.4 lakh children are getting TB every year. And the contribution of global burden of TB, pediatric TB, is around 31%. And the NTP reports, our NTP reports show that around 6% of children are below 14 years. And the detection gap, there's a huge detection gap of 56% in pediatric cases, and which is around 70% in less than 5 years. So this 4 points itself shows the importance of pediatric TB. So to discuss this topic in detail, how to approach a pediatric case, we have here our eminent speaker, Dr. T.U. Sukumaran sir. As we all know, he's a clinician of profound experience, and I have the opportunity to closely see how he sees his patients, and he always keeps the basis of public health in his approach. And his He's a past National IAP President 2011 and is a patron of Pediatric Asthma and Aerosol Therapy in IAP Kerala Presidential Action Plan 2020. And recently he gave Chandilal Oration National TB Code. And at present he's working as Senior Consultant Pediatric Caritas Hospital. And he also has a lot of published papers in reputed journals and has many research works to his credit. And he also almost a contributor of more than 10 books. And he's such a writer too. So I welcome beloved you, Sukumaran sir, for this wonderful session. Thank you, sir. Over to you, sir.
Okay. Manu, can I share the slides now? Manu.
Yes, sir, definitely.
Okay. Can you see the slides now, Manu?
Yes, sir. Yes, sir.
Audible?
Yeah, audible.
Okay. Beloved Kottayam District Bank President, my friend Dr. Patani, Secretary Dr. Preja, HOD of Pediatrics, ICH Kottayam, Dr. Darli, my beloved friends, Dr. C. Jayagumar, PR Jayagumar, other dignitaries of the dais, on the dais, and my beloved brothers and sisters of the Academy and dear friends. And also, this session is going to be chaired by Dr. Gayatri, who was also a past student of our own Pushpagiri Institute of Medical Science. Once again, I welcome Dr. Gayatri also to this CMB program. As Dr. Jayamar has pointed out, there are a lot of controversies in the diagnosis and management of pediatric tuberculosis. Dr. Gayatri has already gone to the statistics. I will be just going to a clinical approach. It's only a clinical approach to the problem of childhood tuberculosis. Why there is so much controversy in the diagnosis of tuberculosis? This is because the gold standard for diagnosis of adult tuberculosis is demonstration of the acid bacilli, mycobacterium. But unfortunately in children, the childhood tuberculosis is a positive bacillus disease, and the positive AFB is seen only in 15 to 20% of children. So it is very difficult to demonstrate AFB also in children. So there is a lot of confusion in that. And also there are a lot of confusion in the management also. 3 drugs, 2 drugs like that, there's a lot of confusion is there. So I will try to clear some of these doubts also now. And fortunately, as Gayatri has remarked, the prevalence of tuberculosis is less in Kerala now. Among all states, I think Delhi is leading, and Kerala, this TB cases are seen here. Now also, we are also, as clinicians also, we are seeing less cases. I joined Caritas Hospital 2 years back. It's becoming 2 years. For the last 2 years, I have not diagnosed TB, or I have not started anti-TB treatment for any of my patients. So it has become less now. And the only problem that we see is only BCG adenitis. And the last 2 years, I have seen 3 or 4 children who was presented with a BCG adenitis, for which no anti-TB drugs are required. So otherwise, I have not started anti-TB treatment for none of these patients for the last 2 years. So as with any clinical problem, one should take a detailed history, a thorough clinical examination. Then you must investigate and you must manage. And I will just put up a case scenario. This is a story of a 2-year-old Suresh who is brought to you for second opinion. This is a very common problem that we see. I diagnose a TB from X-ray test. Then the same patient is not very happy with me. They goes to Mitira Hospital. They may meet Patani there. Then Patani may say, there is no TB. They go to Jayagumar. Jayagumar also see the X-ray. Jayagumar say, since Dr. Sukumaran has diagnosed TB, TB is still there. So there's a lot of confusion is there. So this is a common problem that we see. So the 2-year-old Suresh has bought for second opinion because he is diagnosed to have TB, and he has started asked to start ATT. And this child is presented with on and off fever for 1 month, on and off fever for 1 month, recurrent calls. Child is not eating well. Child is not gaining weight. What are your thoughts now? Is it TB, or you must treat it as TB or send the child away? So now, because it's a suspected TB, and so you must take a very detailed history investigations before you start treatment in this child. So these are the main symptoms of TB. A child presenting with fever for more than 2 weeks. The 2 weeks is very important, and fever lasting for more than 2 weeks. It should be daily fever. Child presenting with fever of 2 weeks. Intermittent fever will not be there, but 2 weeks fever, prolonged fever for 2 weeks. Then second symptom is unremitting cough for more than 2 weeks. Again, everything is in 2. 2 weeks fever, 2 weeks cough. But it should be unremitting cough. The commonest cause for a recurrent cough in a child, I think the commonest cause will be asthma. A child with asthma, they usually present with a nocturnal cough. Around 2 a.m., 3 a.m., they wake up with cough. And it is intermittent. You give a salbutamol puff, the cough subsides. After 1 week, the child again develops cough. That is not suggestive of TB. Every day, the child will have cough for every day. So everyday cough for more than 2 weeks. The recent loss of weight, more than 5% in the past 3 weeks. And non-specific complaints if there is contact with TB. History of contact with TB is very important. And what is a contact? The previous definition is that if a child comes into contact with a person who is taking anti-TB treatment or has taken anti-TB treatment within a period of 2 years, can be taken as a contact. But it is unlikely to be TB if the child is present with cough with cold. The child is having cough and cold. That's very common in a child. A child present with the rhinitis and cough. Recurrent cough like asthma. Recurrent fever, maybe a viral fever. This may not be suggestive of asthma. Like in our index case, may not be TB for this child. And this is our national tuberculosis control program. This is the diagnostic chart for TB in a child. The thing is that any child is presenting with these 3 symptoms: more than 2 weeks fever, 2 weeks cough, weight loss. And the most important investigation is now they say this: you must take a chest X-ray should be taken. You take a chest X-ray. If the chest X-ray is highly suggestive, you must look for the expected sputum or a gastric lavage or induced sputum for an NDEP approved NAT. That is nucleic acid amplification test for MTB. So after taking an X-ray, you must go for an NAT, nucleic acid amplification test. If it is positive, it will be taken as a microbiologically confirmed TB. And after confirming this case, you must look for a rifampicin resistance if detected, reconfirm and follow a rifampicin resistant pathway. If rifampicin resistance is not detected, treat with first line anti-TB drugs. Then if the chest X-ray shows non-specific changes, shadows, give a course of appropriate antibiotic. Appropriate antibiotic may be, the child may be given an antibiotic like amoxicillin or amoxicillin. Don't give a fluoroquinolone now, fluoroquinolones, because fluoroquinolones have got anti-TB effect is there. And also lilisol should not be given because they may have anti-TB effect is there. But if the child is having a persistent symptoms, again, you can see a NAT. If a NAT is negative, look for any other site for a significant enlarged peripheral lymph nodes, lymphadenopathy. Then if the lymph nodes are there, you can do a lymph node aspirate and look for a CB NAT in the lymph node aspirate. And consider repeat NAT from a better quality specimen, or you can look for an alternative specimen like BAL, bronchoalveolar lavage, or aspirate, depending on the availability and feasibility. May seek review from a higher center. If NAT is positive, it is taken as a microbiologically confirmed TB. If NAT is negative or repeat test is not indicated, it should be taken as there is no other likely alternative diagnosis and should be treated as a clinically diagnosed probable TB case. So it should be a clinically diagnosed probable TB case. Dear friends, by looking in this chart, what is the most important investigation that is lacking in this flow chart now? Somebody can answer. What is the most important investigation that is lacking that we usually do? Which is lacking here.
Mando test.
I think Mando is lacking here because they have not mentioned about Mando. Now I think the importance of Mando is very less now because The Mando should be done with 2 tubercle units. Such Mando is not available now. Stocks are completed, is not available now. And a Mando test, positive Mando, cannot distinguish between a tuberculosis disease and a tuberculosis infection. And also there are, Mando may be positive in a child who has taken BCG vaccination. And as you know, there are a lot of false negative Mando can be there, as in a child with severe malnutrition, child on immunosuppressive drugs, child with high fever, child with a high viral fever, then severe forms of tuberculosis like TBM, biliary tuberculosis, typhoid fever. The child is in an incubation period of tuberculosis. Again, the Mando may be no. No, so Mando is given no importance now. Now, most probably, another test that may replace Mando may be what is called a CTB test. CTB stands for cutaneous TB test, which may come in big number later. Cutaneous TB test is specific for Mycobacterium tuberculosis because we are injecting an antigen that is called the injected antigen, ISAT antigen, and also culture filtrate antigen, which is specifically seen in Mycobacterium and not seen in bovine tuberculosis. And you give it transcutaneously, and you read the induration after 48 to 72 hours. If induration is more than 5, it is taken as a positive CTB test. I think this test will come in a big way after this. Now, HIV testing should be offered to all children diagnosed with TB. And coming to our clinical examination is very important. This is a very common findings previously. Now such cases are not seen. A child present with a multiple enlarged lymph nodes, non-tender, matted lymph nodes with sinuses, scars. Lymph nodes are more commonly seen in the posterior cervical and supraclavicular region. It is suggestive of tuberculosis lymph node. This is a characteristic pictular conjunctivitis. The other conditions that produce flicton are streptococcal infection and web infestations, again ulcerative colitis, TB, etc. This is a tuberculosis, you can see a tuberculosis dactylitis, swelling of the interphalangeal joints, a gibbous deformity, it may be due to tuberculosis of the spine. Here you can see scoliosis. But nowadays, these forms of tuberculosis are not seen now. These are some of my old patients, some 10 years back, who was presented with TB of the spine. Now coming to the investigations in TB, mainly you must do a direct test for detection of Mycobacterium tuberculosis, and by demonstrating AFP in the sputum or body fluids or lymph node, grow AFP in culture as a solid or liquid medium, detect AFP using nucleic acid amplification test, and the indirect test may be detection of host response to Mycobacterium. And tuberculosis skin test is written here, is a very old slide, and radiology. Coming to sputum, Mycobacterium in sputum and body fluids, the old seal needles technique can demonstrate sputum AFP. If the AFP is more than 10,000 bacilli per ml, and you can get the results within 1 hour, and it's low cost, high operator dependent. But the only problem is cannot differentiate between live and dead AFP and non-tuberculous Mycobacteria. Coming to the CBNAT test, cassette-based nucleic acid amplification test, the test available are CBNAT or gene-expert TB. It is endorsed by WHO. It is a hemi-nested cartridge-based real-time PCR test. It detects Mycobacterium tuberculosis and rifampicin resistance. I think they said it's within 105 minutes, so early. And you can see that the CBNAT may be positive in presence of 131 organisms per ml of sputum. Results are obtained within 2 hours, but culture take 2 days, and direct smear more than 10,000 organisms should be there, and results should be there within 1 hour. And this is all manual tests, the same high percentage test. The problem is that the 2 tuberculin test units are not available now, and I think it is out of our discussion now. And I had told you about all these things. Induration more than 10 millimeters in an immunocompetent child taken as positive. Induration more than 5 in immunosuppressant is positive. There are a lot of conditions in which there's a false negative Mando, and also there are conditions in which you get a false positive Mando can also be there. This is very important. If a child does not come for results, a positive results can be read even after 7 days. Usually, Mando should be read within 40 to 72 hours, but now we say that you can up to 7 days you can read if it is positive. Coming to X-rays, the radiological appearance may suggest the cytopathology. In the lateral film detect hilar adenitis not clearly appreciated in the film, and all persistent radiological lesions may be suggestive of TB. Maybe any lesion in the X-ray may be suggestive. If Mando is negative, but X-ray is suggestive, the child should be investigated. Diagnosing only by radiology to be discouraged. By radiology alone, you will not be able to diagnose TB. These are some of the suggestive radiological findings. Cavitation in the lung, miliary mottling, calcification in the hilum or lung parenchyma, a lymphadenopathy, mediastinal hilar, or a child is having a persistent pneumonia or cold abscess. I will go show you some of the X-rays. Here you can see this X-ray just view. You can see the primary focus here, Ghon's focus if you look carefully, and you can see the lymph node here. See, hilar lymph nodes are usually having a rounded opacity with a convex outer margin like this. A rounded opacity with a convex outer margin may be suggestive of a hilar lymph node. Again, you can see a Ghon's focus here with a hilar lymph node, convex outer margin with a rounded opacity with a convex outer margin. Here you can see hilar and mediastinal nodes. Here you can see the mediastinal lymph node. Here you can see a paratracheal lymph node here. It may be suggestive of TB. These are only suggestive of TB, not definite. So lymph node disease with airway compression. You can see the multiple lymph nodes here, and you can see the collapse middle lobe. This is called a middle lobe syndrome. In the PGs here, what is the other name for that? A middle lobe collapse due to tuberculosis lymph node pressing on the right middle lobe bronchus. What is the name for this? What is the syndrome called? It is called Brock's syndrome, BROCKS, Brock's syndrome. Here you can say lymph node TB. You can see the lymph nodes here with collapse here, collapse of the right middle lobe. You can see the right cardiac body is seen only in the upper part, lower part is not seen. So collapse of the right middle lobe. Here you can see a large lymph node, a mediastinal lymph node due to tuberculosis. Here you can see a lymph node TB with cavitation. You can see cavitation here. Here may be a reactivation tuberculosis. Lymph node disease with an expansile lobar pneumonia with cavitation. In adolescent girl, it is a reactivation tuberculosis. This is a very typical miliary tuberculosis. You can see miliary mottling. But again, miliary mottling may be suggestive of TB. But there are a lot of other conditions in which miliary mottling can be there. It can be there in pulmonary eosinophilia, in Lovelace syndrome, in rheumatoid lung, in sarcoidosis, pneumoconiosis. So there are a lot of conditions. The question that is asked in the examination. Other cause of miliary mottling. A lot of other conditions can be there, but the commonest condition may be tuberculosis in a child. Here you can see a pleural effusion in a child. You can see lymph node also, hilar, paratracheal lymph node, and you can see the carinal lymph node. And you can see an effusion here because there is an uniform haziness with an upper level in the axilla. There's a positive Elias curve is there. So you get a pleural effusion may be suggestive of TB. This is also a very old X-ray, cold abscess. These things are not seen now. But senior people like Patani might have seen. Cold abscess here. You can see a paraspinal abscess. But you can also look for the collapse of the spine also you must look for. There's a paraspinal abscess here. Here you can see a mediastinal lymphadenopathy in the same patient. So there's a port spine. Now coming to the management. So management have again be changed in the newer NTP guidelines, National Tuberculosis Elimination Program Previously, there were 2 or 3 groups were there, but fortunately for us, there is only one group now. New or previously treated cases, you can treat with 2 HRE with 4 HRE. 2 months course of INH rifampicin, pyrazinamide, ethambutol should be given daily. That's the intensive phase, followed by a continuation phase of 4 months course of INH and rifampicin. There is no separate regime for retreatment cases. These drugs are given daily. The previous RNDCP guidelines, the drugs are given once in 2 days or 3 times a week. The dose of the drugs are according to the body weight. Fixed drug combination tablet should be used. Loose drug should be needed as substitutions in the case of adverse drug reaction. No need for extension of the continuous of the intensive phase. No extension should be given, but continuation phase may be extended by 12 to 24 weeks in severe forms of tuberculosis like CNS tuberculosis, skeletal disseminated tuberculosis. So the continuation phase may be nearly 10 months based on the clinical decision of the treating physician. Extension beyond 12 months should be on recommendation of expert for the consent field. So this is the guidelines by the new TB elimination group. But recently, 1 week back, there's a very good article has come in New England Journal of Medicine. It's called a SHINE study. And they have conducted a study comparing the duration of the continuous phase, the continuation phase. They have divided these children into 2 groups, around 1,220 children. And one group was given 4 months course of continuation phase, and the other group was given only 2 months continuation phase. And these children had non-severe forms of tuberculosis, non-severe forms of tuberculosis. And it is found that even 2 months course of continuation phase is found to be effective in this SHINE study group. Just come in New England Journal. So I think most probably this regime will come up soon. 2 HRE study followed by 2 HRE as per the SHINE study, which was conducted in India also, in Pune, BJ Medical College, Pune, South Africa, Uganda, and some other African countries. This study was conducted. Again, they have found that 2 months continuation phase is as effective as 4 months continuation phase. And now this is the treatment of drug-sensitive TB. These are the various dosage schedules and drugs available now. Now coming to the dosage, you can see that the daily dosage is a bit less. INH 10 milligram per kg, rifampicin 15, pyrazinamide 30, ethambutol 20 to 25, and streptomycin 15 milligram per kg is the dose. ATT daily or intermittent. Previously it was intermittent regime. Now this according to the WHO and our NDP guidelines, it is daily regime. Daily therapy can be given with stress on compliance to treatment and completion of treatment. And this is a very good study that has come from all the institute. Intermittent or short course chemotherapy of tuberculosis in children. The meta-analysis of randomized controlled study. Previously, people told that the intermittent regime is found to be equally effective or better than a daily regime. But according to this study, they have found that twice weekly intermittent regime, twice weekly is far inferior to a daily regime, and daily regime should be given for children. And this is following a Cochrane search for randomized trial for anti-TB regime containing rifampicin in children 16 years or less with tuberculosis. And they have reviewed all this Cochrane review and found that the daily regime is superior than intermittent regime. I will not be going to this complex management of drug-resistant TB. Then in a second case, there is a very common problem that we have seen. And this is the commonest TB case that we see probably now. This is a 4-month-old girl who was treated with a swelling in the left axilla, progressively increasing, and no constitutional symptoms. And recently also I have seen a child, one of the daughter of one of our postgraduate students was presented with a swelling like this. It is none other than a BCG adenitis. Following BCG vaccination, few weeks or months after BCG, they are presented with a swelling like this. And most of the cases are regress spontaneously within 4 to 6 months. Nodes may liquefy, there can be abscess, but if you do an appendicity, you can demonstrate the AFB also, but it is a bovine bacteria, not human bacteria. And don't mistake for tuberculosis disease. And there is no role for ATD also. If abscess is there, you can drain the abscess. There is no role for anti-TB treatment for BCG adenitis. It is seen that the BCG adenitis is more commonly seen if BCG is given subcutaneously instead of giving intradermally. If it is given subcutaneously, and if the dose of the BCG is high, the chance of BCG adenitis is high also. And coming to these are some of the newer drugs for treatment. And these are the old drugs, levofloxacin, rifampicin, etoxacinide is also being tried. This is a newer drug, Dilamine, bedaquiline, rifampicin, and clofazimine. These drugs are under trial for multi-resistant TB in children also. And I just summarize the salient changes that is present in the National Tuberculosis Elimination Program when you compare with our previous RNDCP. Upfront use of CBNAT in smear-negative PTB patients, extrapulmonary TB, pediatric TB, HIV patients for diagnosis of TB. So CBNAT is given importance now. Introduction of daily drug regime instead of intermittent regime. Then ethambutol has been included under continuation phase. I think there is no problem in giving ethambutol for months. Previously, we thought that the main goal with ethambutol is optic neuritis, but it is reversible and is less commonly seen in children also. So there is no problem in continuing the phase for 4 months. Removal of category T as 2 has been removed. The previously treated recurrence treatment after loss to follow up failure. All these children need to be evaluated for drug-resistant TB. Then one more thing is pyridoxine is supplemented 10 milligram for children with INH. There is provision of multiple weight bands and options are there. This children needs long-term follow-up. So to conclude this talk, as Dr. KGMOA said, a lot of confusion is there in the diagnosis and management of TB now. But TB cannot be diagnosed with a simple investigations. So I must take a detailed history, go for a physical examination, investigation and management. With one single investigation alone, you cannot go for the diagnosis. Always take an X-ray, try to demonstrate the AFB in one of the body fluids, or look for a positive CBNAT test, which should be positive. Even for lymph node to be tuberculosis meningitis and also a TB of the other body fluids also, you can look for a positive nucleic acid amplification test. And if these tests are positive, you can start with 2-HR-SAD with 4-HRE, the treatment of choice. And there is no confusion in this. And I think in the next few years, most probably, I think the reduced duration treatment like SHINE protocol may come up soon. Thank you very much for your patience. If there are any questions, we'll take up.
Thank you, sir. Am I audible?
Yes, yes.
Yeah. Thank you, sir. Actually, as expected, it was a very wonderful and elaborative session, very informative too. And at least every participant has learned something new from this, has broadened their knowledge on pediatric epidemiology and management. This session is open for any burning questions and queries.
There is one question.
Yes.
Prophylaxis for contacts.
That is a different talk.
Yeah.
I have not touched upon latent TB or positive contact. Dr. Bala will be talking in detail. Because even the management of TB, the most confusing aspect now is management of latent tuberculosis, and a lot of newer things has come up. That is why I have left that. Bala will be talking on latent.
Right. Yes, sir. Gayatri Madam, would you like to say something? Add.
Okay, as sir said regarding CTB, actually CTB trial has been going on in India, and in Kerala 3 districts like Kannur, Thrissur and Kollam has undergone that trial, and the results will be published soon by ISMA. Then if the results is positive, we can start CTB within 1 year itself. So the Mando can be replaced by CTB, so it will be easy for pediatricians to move forward with CTB, so that be easy to it is equivalent to IGRA testing. So the time consuming and other difficulties can be a little reduced if the CTP has launched. So that's a good.
Thank you, as Dr. Gayatri has said regarding CTB. C stands for cutaneous TB
Cutaneous
test,
TB, yeah.
and a study has been done in Old Institute, and actually they have presented it in one of our conferences. 2 years back, they have presented. Dr. Kabra from Delhi has presented his results from CTB test. The difference between CTB and Manto. CTB is almost same as IGRA, because IGRA also we are using the same antigen. And we are culture filtered antigen, culture filtered and ISAT antigen. The same antigen is given cutaneously for our children, and this antigen is specific for mycobacterial tuberculosis, and this antigen is not present in BCG also, and non-mycobacterial tuberculosis also. So this is specific for mycobacterium. So if this test is positive, CTB more than 5 millimeters, it will be more specific for diagnosis of TB.
Thank you, sir.
Okay.
Any more questions?
I think any more questions?
I think questions will come last after
Yes,
Bala's
sir.
talk.
Okay, fine. Okay, sir. We will go for the next
Okay.
session then. Thank you, sir. Thank you, madam. Our next session is latent TB infection, and the moderator is Dr. Twinkle Prabhakaran, District TB Officer, Kottayam. He had his technical and operational guidelines and quality assurance training from National Tuberculosis Institute, Bangalore, and he has been DTO since 2 years. Twinkle, sir.
Yes. Thank you, Dr. Preja. Am I audible?
Yes, sir. Yes, sir. You're audible.
Kelkavo. Okay, thank you.
Okay.
Respected Pathani sir, respected Sukumaran sir, Jayakumar sir, Dr. Balendra sir, Dr. Manu Rokshabari. IAP was giving a very warm support for the program since last many years. The program was doing many changes since last 3-4 years, and I remember every year IAP is addressing the changes and communicating it towards its members in the district. And I'm thanking IAP, and I'm also overwhelming by the huge presence, like 78 participants. No, now it is 79 participants are there in our virtual platform. Thank you all for joining with us. And as the next topic is latent TB management. As our nation is moving and working forward towards the elimination of tuberculosis, management of latent TB is a key component. Previously, we used to manage the tuberculosis or latent TB in pediatric age group less than 5, and among the immunosuppressive group like HIV infected patients. Now we are addressing a broad spectrum. It includes adult immunosuppressants, organ transplants, and many other, like those are waiting for organ transplant, those are on steroid therapy. So LTBI or latent TB management is a key component for reaching our goal of TB elimination. And here today we are having Dr. Balendra sir. He is an eminent speaker, and I am welcoming sir. Dr. Balendra sir, please.
Thank you. Thank you, Dr. Tingle. First of all, let me thank Dr. Patan sir and Dr. Preja, Dr. Darli madam for giving me an opportunity to present this topic, very important topic for the general practitioners. But at the same time, it's very difficult to present after a seasoned speaker like Sukumaran sir, who has a caliber of national and international level. Still, I will try my best. In another 25 to 30 minutes, what I'm going to tell you is about the LTBA basics and the eligibility criteria, something about IGRA, something about diagnosis and treatment of LTBA, some case scenarios, and some FAQs. And if time permits, I will be dealing with other facts of LTBA. Am I audible and vision is the?
Yes,
Yes, sir. Perfect.
Yes. So in India, you all know that 3.42 lakh children get TB every year, and globally it is around 1.1 million, where 11% of the population are children. And out of this, 31% of the global burden is taken by India. And as Dr. Gayatri said, 8.5 cases of reported to NTP are children below the age of 14 years. And there is a huge detection gap, overall 56%. And in children, pulmonary TB is most common, but extrapulmonary TB, as compared to adults, it is more common in children, especially the lymph node TB. And active TB is only the tip of story. What lies beneath is a reservoir of trouble. You can see that today TB is around 10 million active cases worldwide. And tomorrow, if you go like this, the latent TB infection itself can come up to 17 crores. That 10%, considering the fact that 10% will develop TB in their lifetime, that will come around 1.7 crores of open case of TB. So that is the importance of LTBI. And this is the facts 2 years back, 2020 pediatric TB from Kerala. We have around 179 cases under 5, a total around 6,300 cases, of which that accounts for 8.5%. So this overall huge detection gap, that is 70% in less than 5 years, 35%, 40% in the 5 to 14 years age group, and overall 35%. And this is the causes for this detection gap. One is challenges with the specimen collection, as Sukumaran sir has said. Then challenges in the bacteriological confirmation of TB in young children due to the positive nature. Lack of highly sensitive point of care, CTB. And from 2020, that C19 pandemic has a negative impact on TB notification, even though in 2021, we had more cases of TB notification. So why Kerala was selected for the programmatic management of LTBA? The most important reason is the declining growth rate. The decadal growth rate is 4.83%, much lower than that of the country, which is around 17.6%. And Pathanamthitta and Idukki districts in Kerala report the negative growth rate. And except one district, maybe Malappuram, all districts in Kerala have a declining child population. And the infant mortality, it's not 7, even it is below, should come below 5. And the high literacy rate of 96% in males and 92% in female. And the systematically organized primary healthcare system. In our state, the primary healthcare services have been systematically organized in rural areas of the state. And there is less urban-rural disparity. We have a lot of specialists even in the periphery, even physicians, pediatricians, or dermatologists. All specialists are there in the periphery. So there is not much difference between urban and rural disparity. And there is no HIV transmission in Kerala. So these are the reasons why our state has been taken for the LTBA management for the first time in India. And the proportion of TB patients with multi-drug resistant TB is comparatively lower in Kerala. Among new TB patients, rifampicin resistance is less than 1%, and among previously it was 3.5%. And recurrence rate is also less than 5%. And the joint monitoring mission. So these are all the reasons why Kerala has been selected and why our TB care is good. The steps management system for TB elimination private sector. When our primary health system is very good, in the private sector, the steps is very good. So we get a lot of notification from the private hospitals also. The annual risk of TB infection is 1/5 that of the national estimates. So, and another fact is that previously 21% of the TB diagnosis from medical college services, but now it is only 9%. That shows how much our periphery is good. Now the Kerala TB elimination mission has started to achieve the sustainable development goals related to TB. The mission is envisaged as a people's movement, and the strategic document, which is customized version of the national strategic plan, has enumerated 48 activities. The government of Kerala has launched this mission aligning with the SDG with the objective to achieve TB elimination by 2025 and zero death and zero catastrophic expenditure for the families and zero stigma and discrimination. That is the purpose of this TB elimination mission. And out of 48, 10 components related to the Akshay Kerala, and of which the most important 3 are the TB preventive therapy to all children less than 15 years, which was started during our presidential period of Dr. M. Narayan sir. It was inaugurated in November 2020, and TB services at doorsteps and upfront molecular tests for TB diagnosis for children. So this is the training program which was started in October. The first TOT was started on 22nd of October. And after that, there was a meeting with the whole heads of the health sectors. And then the inauguration of the TB-free air for every child in Kerala by the Honorable Governor of Kerala on November 1st, Kerala Piravi Dinam. And the National TB Elimination Program has decided to commitment to identify and report all adverse reaction of following this LTBA. So this was October. This was various programs during the late 2020s. This is the bulletin by the state TB cell, and the TB-free hour for every child in Kerala. Protecting child rights was the theme of Dr. M. Narayanan, and TB-free air was a right for every child. And IAP has raised voice for children, as Dr. Twingle has said. So IAP and state TB cell and district TB cell has gone together for the welfare of the children. The TB preventive therapy, the prevention of active disease is a critical component of the WHO and TB strategy by 2030. So that is it's a very critical component of the WHO and TB strategy. And the draft national plan for LTBA developed by the National Technical Group is ready, and Kerala was the first state to customize. Now Tamil Nadu has followed this. Previously the LTBA management was up to 6 years. Now it has gone up to 15 years, and now recently adults also have been started on LTBA management. What are the prerequisites to roll out LTBA services? The training of all pediatricians, program management staff, treatment supporters, lab assessment should be good, logistics should be good, and setting of district pediatric TB committees. So these are the prerequisites for the LTBA services. Training has already over. Lab is ready, but logistics, there is some problem, but still it's going on well in many of the states, many of the districts, and the district pediatric TB committees also is going well with almost all districts. Now let us come to what is LTBA. So this LTBA is defined as a state of persistent immune response in relation to Mycobacterium tuberculosis antigen with no evidence of clinically manifest disease. That is a normal, LTBA means a normal child. Externally we see that it is a normal child. So from the pool of infected but asymptomatic persons, most cases of TB will arise. On average, 5 to 10% of those infected will develop active TB disease over the course of their lives. And the risk of active TB disease after infection depends on several factors, the most important being the immunological status. And the risk of developing TB disease after LTBA decreases 90% from 9.1% for those not taking LTBA to 1.2% for those not taken the same. So that is the importance of LTBA. So the chance for getting the active TB disease is 90% less for those who are taken LTBA TPT. And effective implementation of the TB preventive therapy alone will result in decline in annual TB incidence by 12%. So 12% decline in incidence, 90% less chance of getting an active disease. These are the two important factors, important benefits of LTBA management if given properly. This is a graph which has shown that in 2009 there were high case finding efforts that shows 27,000 cases of TB. Now it has come down to 20,700 in 2019. There's a high case finding efforts increasing at 7.5% annually, and low case detection declining at 3% annually. And the private sector drugs sales declining at 10%, and kit formulation ATT has declined by 90%. And the TB notification also during the COVID period also it was comparatively less, but estimated 1,500 cases remains undiagnosed in the community during the period of 2020. So the principle of PMLTBA in Kerala, there's a cascade of care approach and followed. while implementing the management in children and adolescents. So that is what is cascade of care. Cascade of care approach is you reach out, you screen, you rule out the active disease, and give a continuing care of LTBI management. This is cascade of care approach. And the Kerala with a lower instance of pediatric TB and LTBI, it is suggested to have a test and treat approach to the management of LTBI. So let us see what is household contact. As Sukumaran sir said earlier, for ruling out active disease, we have for tuberculosis, it is 2 years, but for LTBI, household contact definition is a person who shared the same enclosed living space as the index patient for 1 or more nights or for frequent or extended daytime periods during the 3 months before the start of current treatment. So 3 months is a cutoff for household contact definition. And now next 2-3 slides are very important. Who are eligible for LTBI management, that is children less than 5 years who are household contacts of microbiologically confirmed pulmonary tuberculosis may continue to be given TPT after ruling of active TB. So there are 6 eligibility criteria. All the 6 we have to rule out active TB diseases. That is why I underline that after ruling out active TB disease. So children less than 5 years and household contacts of open cases. Second is child born to mother who has diagnosed to have TB in pregnancy should receive TPT provided congenital TB has been ruled out. Third is children between the age of 5 to 15 years. That is the new thing. Previously, it is the first 2 eligibility criteria was there before, but now from last 1.5 years, children between 5 to 15 years who are household contacts of microbiologically confirmed TB should be systematically tested for LTBI. And if found to be LTBI, that is do IGRA, then should offer treatment of the same after ruling of active TB. But now it is said that even for less than 5 years, even if the child is asymptomatic, it's better to rule out active TB by taking a minimum chest X-ray. And in 5 to 15 years, always rule out active disease even if the child is. The fourth is the adolescents. 12 months to 15 years, living with HIV should be given TPT after ruling out TB. So in this age group, no contact is needed. That is 12 months to 15 years, living with HIV, but have to rule out active TB, but contact is not needed. And children less than 12 months, contact is needed to give TPT, but always rule out active TB. And the last criteria, that is children less than 15 years on steroids for more than 2 milligram per kg, more than 2 weeks, like nephrotic syndrome, leukemia. They have to be systematically tested for LTBI, that is do IGRA. So, and also rule out active disease. Here also no contact is needed. So before starting steroids for nephrotic syndrome, leukemia and all, to do IGRA and then start TPT. So I hope it is clear. So there are 6 eligibility criteria for LTBI. Now let us come to what is interferon gamma release assay, IGRA. So this evolution, this IGRA is not a new thing. It has been there for the beginning of this decade. That is first generation quantiferon TB has been approved by FDA in 2001. And it was a breakthrough because TST becomes a blood test. Previously, Mando was there before and it was a skin test. Now it is a blood test. The second generation quantiferon TB cold is a liquid antigen. It was approved in 2004. The benchmark is that there is no cross-reactivity with BCG, unlike in the first generation. The third generation quantiferon TB cold, the benchmark is that it's scalable and easily automated. And that was in 2007. And the fourth generation, the present used quantiferon TB Gold Plus, that was approved in 2017. And the benchmark is that addition of patented CD8 antigens, that the potential biomarker of intracellular TB burden has been introduced. So what are the differences between IGRA and tuberculin test? IGRA is an in vitro, whereas tuberculin is an in vitro test. And IGRA is a well-defined antigens, as Sukumaran sir said, the ISAT, that is early secreted antigenic target 6, and the culture filtrate protein, CFP10. These two are the mycobacterium tuberculosis specific antigens in IGRA, which is not there in tuberculin skin test. There is minimum interreadable variability. Good transport medium is needed for IGRA, that's a disadvantage, and which is done on specific days only, because for one kit, 22 samples needed. So we have to wait for 22 samples. So maybe it will take 1 or 2 weeks to do, but it is not an emergency, so that's okay. But the tuberculin skin test can be done on any day. There is there is significant inter-readable variability, and the problem is standardized TST is not available. So the advantages of IGRA, one is can detect TB infection. It has got high specificity and sensitivity, not affected by BCG. There is no boosting, that is doesn't boost response measured by subsequent tests, unlike Mando. Mando, if you do once and if you do again, it can come positive. First maybe negative, the second can become positive, which is not seen in IGRA. Single OPD visit is only required. Results available in 24 hours. Whereas Mando, it is 48 hours, and we have to read there to come again, and it is affected by BCG. The disadvantages of IGRA, it cannot predict disease will progress, but or will progress to disease like Mando. That there is a difficult collection, transport, interpreting, decrease accuracy. The blood samples must be processed within 8 to 30 hours. While so once you take the sample, it should reach within 16 hours, preferably 6 hours at the center, and limited data on less than 5 years of age group, a person exposed to mycovacc and tuberculosis, immunocompromised. So in all these countries, that is why IGRA is not advised in less than 5 years, and expensive, unlike Mando. So this is a comparison of TB skin test and IGRA. I am only concentrating on the CTB. It is CTB, the cutaneous TB specificity is high, same as IGRA. Sensitivity is also high, same as IGRA. The ease of use is easy, field-friendly, single cutoff allows simple test interpretation. That is, it's a point of care test CTB, low cost, and it's a manufacturing. It's a robust with high yield, well-defined, and completely characterized recombinant proteins. It is constantly available in large volumes, and in children it can be done, but it is prepared by the Staten Serum Institute Copenhagen, but it is not yet available commercially because of the COVID pandemic. So hopefully it will reach within a year or two. So this is the burden implementing tools of countries implementing the tools for LTBA. We can see in northern part of Southern America, South America, they are doing TST and chest X-ray like India. We are doing most of the IGRA is done only in Kerala, and but in India most of the part is doing TST and chest X-ray, the screening tools. This IGRA is done maybe in countries, European countries only, and all other parts, even in South Africa, Pakistan, all chest X-ray is done, not even Mando. So IGRA is done in 46 public labs and 16 private labs. That is around 62 centers are there in Kerala. It is like a hub and spoke model from peripheral hospitals where IGRA lab is not co-located. Blood sample collected in lithium heparin blood collection tubes and is transported through the specimen collection and transportation system on prefixed days, so as to reach the lab within 16 hours of collection, and if stored at room temperature, or within 48 hours if at 2 to 8 degrees centigrade. These are the various steps in SOP that sample collection, packing, qualification criteria has to be met, transfer of blood to IGRA tubes to lab, incubation of the tubes, post-incubation collection of plasma, and doing ELISA and do the results. These are the various steps in IGRA. Finally, you will get a computer statement of the results. So the barriers to implement IGRA is high cost. One is the high cost. Second is no budgets allocated. Not clear if IGRA is better than PPD, and IGRA kits not domestically available. Lack of lab infrastructure. Limited availability of lab personnel, and insufficient capacity for specimen transport. So these are the various barriers to implement IGRA. So hopefully by if CTB comes, we will be able to do a point of care test soon. Now coming to the diagnosis of LTBA, as you can see in this picture, to diagnose active TB, there are a lot of tests from sputum culture, microscopy, from symptoms, from chest X-ray, gene expert, all this can be done. But for diagnostic test for LTBA, what we have is only IGRA and the TST, tuberculin skin test. So before that, whenever you go for diagnosing LTBA, you have to rule out active disease, as Sukumaran sir said. History's clinical examination is very important. Rule out extrapulmonary TB, and always there should be a clinical committee, because there is no gold standard test for diagnosis of LTBA. So there should be a committee at the district level. So these are the algorithm for the diagnosis of LTBA among HIV negative eligible children and adolescents in the age group 5 to 15 years. So whenever a child comes with the symptoms of TB like cough, hemoptysis, fever, night sweats, weight loss, chest pain, shortness of breath, fatigue, not eating well, if any of these symptoms are present, investigate for active TB disease as per guidelines. If active disease is present, treat for active tuberculosis, and if active TB disease is ruled out, test for LTBA doing IGRA, and if positive, consider for treatment. If IGRA negative, then you can leave it alone. But if there are no symptoms are present, if none of the symptoms are present, but there is a history of contact, do an IGRA. If it is negative, leave that child alone. But if it is the IGRA is positive, take an X-ray. If there is no abnormality, rule out extrapulmonary tuberculosis by examining the lymph nodes. And if there is no evidence of extrapulmonary tuberculosis, start do the baseline assessment and treat as LTBA. But if the chest X-ray, if there is any abnormality, then rule out active TB disease. And if there is no active disease, then you can go for LTBA management. So what is LTBA management? That is what Dr. Georgia has asked in the during the previous session. What are the how do you treat a contact with the tuberculosis? So this is the 2020 WHO guidelines. Recently, the 2022 guidelines has as Suman sir has said, 2022 guidelines, there are some 8 changes in the diagnosis. And in 2020, the last one, multi-drug resistant tuberculosis. Previously, we used to say that for multi-drug resistant TB contacts, we have to follow up. You don't give LTBA management, you just follow up. But now, levofloxacin and moxifloxacin has been approved for treatment of the multi-drug resistant tuberculosis. So there are 5 regimes for latent TB treatment. The existing regime is the 6 or 9 months of INH, which we have been using for long, till 1 year back. Then the 3 months of INH and rifampicin, that is in areas where there is low TB incidence, that is a new recommendation. That is why Kerala has been selected for INH and rifampicin, because the area should be of low TB incidence. Then there are 4 months of rifampicin, 3 months weekly rifampicin with INH. That is being given now to adults. It is a new recommendation. And the last is a 1 month regime of daily rifampicin plus isoniazid. This is a new recommendation in the 2022 WHO guidelines. The treatment of LTBA preferred regime in Kerala is 3 months of isoniazid plus rifampicin daily after ruling out active tuberculosis. And why? You must be wondering why 3HR has been used, why other regimes are not used. The first reason is the comparatively lower risk of adverse effects compared to longer duration of INH. 6 months or 9 months of INH, adverse effects is less when compared with 3 months of INH and rifampicin. And the efficacy and safety profile were similar. This 3 months and 6 months, the safety and efficacy similar, and lower risk factors for adverse events and higher adherence rate. So if you had to give only for 3 months, most patients will complete the treatment. Chance of greater adherence and familiarity for the use of pediatricians, because in the early part of this decade, we have been using 6 months HR for treating tuberculosis. Then availability of child-friendly fixed dose combinations. So these are the reasons why HR has been used. And the treatment for LTBA for eligible children, INH isoniazid, the dose of 10 years and older, 5 milligram, less than 10 years, 10 milligram per kg per day. Just remember that for pediatric age group, the dose is always on the highest side. So for less than 10 years, 10, more than 10 years, 5. Similarly, rifampicin, more than 10 years, 10, less than 10 years, 15. So 5, 10, and 10 and 15. Lower dose less than more than 10 years, and higher dose less than 10 years. Then I don't look at this weight band because it's difficult. 1, 2, 3, 4. Even though it is 4 to 7, 8 to 11, you can remember like that. But per kg you can go. Pyridoxine 10 to 25 milligram daily. Always it's better. It's better to give, but it's not easily available. The contraindications for TB preventive therapy, one is contacts of any drug-resistant TB. Previously, it was said that drug-resistant TB contacts should be followed up, not to be given INH and rifampicin because chance of resistance again developing. And active hepatitis, acute or chronic hepatitis, always it's a contraindication. And symptoms of peripheral neuropathy, tingling sensation, the legs, very difficult to get in children. So this is what I said. You don't have to follow this. This is what I said in the 2020 WHO guidelines, what I said earlier. So coming to one case, all these cases we discussed in the Pathanamthitta Pediatric Committee, where District TB Officer Dr. Ricky, Dr. Devi Priya is there, pronounced, then our Jijo Joseph John of Believers, Dr. Asha from Tiruvalla, Dr. Bivin, and Dr. Anju from Kottayam. We used to discuss many cases. I'm presenting these 4 cases which were discussed in the committee. This is a 33-year-old pregnant female with history of pulmonary tuberculosis 8 years ago, was diagnosed with microbiologically confirmed TB and relapsed on July 13th, and started on ATT from the next day. At the time of diagnosis, patient was 8 months pregnant. She gave birth on August 18th, and newborn weighs 2.9 kg. Mother completed 5 weeks of ATT. So whether to start TPT or any investigation to be done on the newborn. So in this case, always you should start TPT even though it is more than 4 weeks. But you have to start APT, but always rule out congenital TB by doing a gastric lavage CBNAT as well as doing an ultrasound abdomen and also a LFT to rule out congenital TB. The second case, this is an 18-month-old baby, completed TPT in June 2021. The index case grandfather re-registered as a treatment failure in August 2021. Child is evaluated, chest X-ray normal, active TB ruled out. Whether to start TPT again. So here the question is the TPT, once you give TPT, there is less chance of getting acute disease again. So it shows the shorter period, it's better to follow up this child and not to start TPT again unless there is any finding of acute disease. Otherwise, we can follow up this child for another 3 months. This third case is a 2-year-old baby girl presenting with a recurrent lower respiratory symptoms, weight loss of 1.5 kg in 2 months, that is more than 5%, and no known contact with the tuberculosis. There is no contact history. No palpable lymph nodes or swelling. Mando was positive. IGRA again positive. I don't know why IGRA was done on this 2-year-old child. It was done at a periphery. And now in February, the ESR has come down to 35 from 65. Then gastric aspirate unit is negative. Ultrasound abdomen is normal, and chest X-ray is shows almost a normal chest X-ray. So how to proceed? Will you give TPT or follow? So in this child, there are many points against prophylaxis. One is this child has been getting recurrent infection in January, when most of the children have been having, because this COVID has come down and many children, the school has started, and we were all getting many recurrent infection in children from January. So 3 episodes in 2 months is not a big issue. Weight loss 1.5 kg, they are done. Weighing machine was at different 2 places. So that is also not very significant. There is no contact history. ESR has come down. And the only problem is chest X-ray is normal. The only problem is the IGRA is positive. Amando is also strongly positive. So in this case, before starting TPT, it's better to follow up this child for active disease signs. So the last case, this is a 12-year-old 44 kg child with no history of weight loss or recurrent infection. Father was abroad and came back in June 2021, and he is on ATT since 3 months, and her elder sister on ATT since 1 month. I have seen this girl in October. The girl had cough 6 weeks ago and treated with antibiotic in a local hospital and admitted on 21st October for 4 days and discharged on ofloxacin. So even after so much awareness classes, we still see children discharged on ofloxacin. At Koranjeri DTC, the IGRA turned positive. IGRA was done. Till 4 months, this child was not investigated for active TB or latent TB. So IGRA was done only in November. It turned out to be positive, and chest X-ray in October was normal, but taken 1 month later showed non-specific shadows, but sputum gastric lab is negative. ESR in October was 70, November 88, December it was 63. Ultrasound abdomen normal was taken 2 months back for UTI. So here the question is, should we repeat CBNet at higher center or go for a LTBA treatment or HRCT chest or start TPT or start ATT? So this is a confusing thing, because CBNet at a higher center always can be done. It's advisable, and hence we referred this case. But CBNet, repeat CBNet was normal, and it was negative. And then next question was whether to do CT for this child, because the repeat X-ray showed some shadows. So we repeat the chest X-ray, and in that we did the CT chest, and in that they just showed, I don't have the filling, but the multiple branching centrilobular nodules in bilateral upper lobe, right middle lobe, and lower lobes, and few of the nodules are coalescing to form a nodular areas of consolidation and large mediastinal lymph nodes. That was the result. And with the discussion with our pediatric committee, we started this child on ATT. Whether it was biopsy has to be done or not it was a question. But already 2 family members with open case of tuberculosis, we thought it is better to start earlier than late. So it was started on ATT, and child is doing well. I'm not going to because of lack of time, already 30 minutes. I'm not going to the baseline assessment and initial counseling, which has to be done. I'm going to only for the last FAQ, some interesting questions, ask questions which can be asked. This is very important. Treatment outcome, treatment completion. We can say when it's good treatment completion, when a child or adolescent initiated on LTBA management completed at least 80% of the recommended dose. That is 68 out of 84 within 120% of the management LTBA management duration. That is 100 days of HR has to be completed. So 80% in 120% of the days. Then only you can say it is a treatment completion. Treatment failed means initiated on LTBA management develop TB disease at any time. And lost to follow-up means for 4 consecutive weeks of 3 HR. If a person is interrupted by for 4 consecutive weeks, it is lost to follow-up. And LTBA management discontinuation due to toxicity because of the drugs, and not evaluated means records lost or transferred to another facility without record of LTBA management. So there's some definitions you have to. And long-term follow-up is also important. This has to be after completing treatment, should be followed every quarter for the next 5 years. And district pediatric TB committee, I'm sure that it is there in all the districts. Should represent from medical college, health service, and private sector. And the DMO and the DTO will be in charge with the pulmonologist as the convener. Convergence of the district TB center as the convener, and meeting should be once in a month or whenever required. We usually meet whenever required only, and at least 3 should fill the forum. And some questions, FAQs which we frequently asked. The child who received a course of TPT again was exposed to active TB. Do we need to offer LTBA treatment again? That was discussed as a case previously, so no need now, only to follow. Is there a chance of developing drug resistance by giving TPT? No chance, because always we are ruling out active disease in this case before starting LTBA. Is pyridoxine mandatory while administering TPT? Pyridoxine can be given, need to be given if we are giving ATT for more than 3 months. So LTBA, even if you don't give because of non-availability, is okay. why are not we testing children less than 5 years who are household contacts of pulmonary TB for LTBA? One reason I said earlier, because the sensitivity, this IGRA is not, they are not done much studies on children less than 5 years and immunosuppressed. The second thing is, as Suman sir has said in the beginning, that maximum chance for children getting active disease is in the age group of less than 1 year. So it's better than around 70%, and after up to 5 years, chances are very high. That's why we don't take risk and we start LTBA management in children less than 5 years. When to stop TPT in case of hepatitis, it's advisable to continue TPT once in a child develops or develops. So always when SGOT SGPT is 3 times normal without symptoms, if it is more than 5 times, stop the drug. If it is with symptoms more than 3 times, then also stop the drug and review after 1 week after doing the liver enzymes. Is in a child less than 5 years with immunosuppressive condition, how to proceed with TPT? Which just to diagnose LTBA. So test is IGRA, and less than 5 years always give. That was also discussed in the eligibility criteria. In less than 5 years with immunosuppressive condition, even if there is no contact, you can give TPT, but always rule out active disease. Is there any recommendation for restarting the regimen once it is interrupted? So this can be in 3 scenarios. One is a child for less than 4 continuous weeks discontinuity. In such a case, start from where the child has left out and give the missing doses. Second scenario, if the child has taken TPT for less than 4 weeks in total and discontinued for any reason for more than 4 weeks, then again you have to rule out active disease. In all the 3 scenarios, you have to rule out active disease, and in this case you can start from the beginning, because discontinuity for reason for more than 4 weeks. So start from the beginning and do rule out active disease. The third scenario, after taking TPT for more than 4 weeks, the child discontinued for more than 4 weeks or discontinued more than 1 week, more than once, then always discuss in your pediatric committee, because resistance chances are more. Always discuss with the pediatric committee and then decide. What if the child develops symptom of active TB while on TPT? Then it's better to start ATT if the child is on. That means it is failure. So that is about LTBA. I have not covered some aspects of LTBA management in the periphery. So I'm ready for take any. Thank you.
Thank you, Balendran sir, for covering all aspects of LTBA in very detailed manner. Thank you. And as the time is running late, shall we go for an open discussion? Dr. Preja.
Yes, sir. I think sir has asked all the questions which he usually asks, and I think no audience has no further questions to discuss. Thank you, sir. Sukumaran sir and Gayatri, anything to contribute from your side? Sir, audible. Unmute, sir.
Bala has presented in an extensive way the diagnosis and management of latent TB. I think in the present scenario, you go for IGRA and treat all these children. First of all, rule active disease. Then if the active disease is ruled out, treat the INH and rifampicin for 3 months. I think that will be the easy one. INH rifampicin for 3 months. That will be better for our state also, I think.
Yes, sir.
Sir,
one more question I want to ask you. Which are the centers in Kottayam where IGRA is now done? Kottayam,
Kanjapalli and Pala.
Kanjapalli,
GH and Pala are the 3 centers where we are performing the IGRA test.
Yeah.
Kanjapalli, Pala and Kottayam, GH.
Medical college undo?
Medical college illa sir. Medical college cheyunnilla.
Pediatric committee undo sare Kottayathu namukku
Pediatric committee നമ്മൾ നേരത്തെ ഫോർമുലേറ്റ് ചെയ്തു. ഇപ്പൊ കോവിഡ് ഒക്കെ കഴിഞ്ഞ സ്ഥിതിക്ക് ഒന്ന് റീവൈറ്റലൈസ് ചെയ്തെടുത്താൽ മതി. GH ബേസ് ചെയ്താണ് നമ്മൾ pediatric committee ഫംഗ്ഷൻ ആക്കിയത്.
Okay, sir.
So regarding IGRA, why can't we start doing it for children less than 5 years? Because the number is less. That's why they have not included. So why can't we, if we are not, if we are doing it, probably we will get a small number, whether, and also we can know that the sensitivity of IGRA in younger children.
IGRA, the studies are, there are not much studies on
Studies,
children less
because
than
there are not much studies. Then we should be doing it for at least a small group of children. Then only the study is likely to come up.
Once the CTB comes, I think that that problem will be solved.
But it will take time, I think. It will take time.
See, JP, the IGRA is not a new test. Even I was doing 24 TB gold. Some 10 to 15 years back, we were doing all these tests. Even for children less than 5 years, as an individual case, we were doing all these tests from the private sector. Private sector we are doing. Less than 5 years also we can do. I think there is no problem. In private sector they are doing. It was being done in a DDRC lab in Trivandrum.
No, DDRC is doing, and we are doing it for some of the selected cases, because sometimes it's so confusing to have Mando. Somebody has done Mando and it is positive, and
but the only problem is a high cost.
Exposures.
The cost was around 2,000 rupees, 2,500, like that.
But that is not a problem for some of our patients.
Then you can try anything.
I think there are no further queries. We'll go to the final session, that is vote of thanks. On behalf of IAP Kottayam President Dr. Joseph Patani sir and our Vice President Darley Madam, I take great pleasure that first I would thank Kottayam KGMOA President Dr. Shabrina D for arranging this combined session with IAP Kottayam as part of World TB Day program. I thank our esteemed speakers, Professor Dr. T. Sukumaran sir, National President IAP 2011, for the brief and stepwise approach to pediatric tuberculosis and giving us practical guides and tips to our general practitioners in how to deal with a pediatric TB case. I thank him for making the topic crystal clear to all of us. I thank our Balendra National Secretary, Environment and Child Health Group, as well as Senior Consultant GH Pathanthita, who is KGMOA President Pathanthita, for taking such a detailed case study and evaluating how to evaluate a latent TB infection. It was really a detailed session, sir, and especially the questions session. It was very eye-opening, and we actually have such cases, and it's very difficult, very confusing topic. Many general practitioners have so many doubts in this topic, and almost all the doubts and queries were touched in detail. Thanks a lot, sir, for your wonderful class. I would like to thank our moderators, Gayatri Madam and Twinkle Sir. Both Gayatri Madam is WHO consultant and Twinkle Sir DTU Kottayam, and they took their time from the busy schedule and agreed to participate in IAP Kottayam session. Thanks to both of you. And I would like to thank Jema Sir, Binikutan Sir, and other senior members, pediatricians, our ICH Superin, and all KGMOA members for participating in today's session and making it a good program, because there were 81 participants. I think majority were from our KGMOA members, and they had a lot of doubts, and I hope all their doubts would have been almost cleared in this session. I thank our Joint Secretary, Dr. Manu, for the technical support in Zoom platform, and rest all IAP members for joining today.